Okay, so with us today is Dr. Safarpour is with us to talk specifically about how autonomic dysfunction really affects the gut and gut health. And Dr. Safarpour is a movement disorder specialist at OHSU, an assistant professor of neurology at the School of Medicine, and also the medical director for the DBS program. So let's give a warm but silent welcome to Dr. Safarpour, and I'll hand it over.
Thank you. Thank you so much, Melissa. And thank you for inviting me. This is a very exciting topic, especially exciting for me because this is my interest in research, and I spend a lot of time reading about gut dysfunction in Parkinson's disease. And often when I first diagnose my patients in clinic, we spend a lot of time talking about changes that can happen in their gut and can affect their medication absorption, response to medications, and as you said, quality of life, which, to sum it up, that's the most important thing when we start thinking about any form of treatment. So what I'm going to do here is that I am going to go a little bit into details of the scientific backgrounds of why we have GI dysfunction in Parkinson's disease, and what type of dysfunctions do we commonly see, what are the common symptoms that we have, and then we will go over treatments and modifications that we can do to improve response to medications. And I briefly want to show you some of the interesting results that I found in one of the recent research that I did on GI dysfunction in PD, that I assume some of you may be people who participated in that research. So you'll get a chance to see the final results. So with that, let's start. So when James Parkinson first explained Parkinson's disease from his observation of how people with Parkinson's disease look like, he did mention changes in GI tract. So in his essay that he wrote back in 1817, even then we knew that Parkinson's disease is not just about shaking and abnormal posture, decreased arm swing, changes in balance. We knew that other things are happening as well. And these other things are the non-motor symptoms, and GI dysfunction being one of those. We always talk about how important it is to talk to your doctor about your motor symptoms, but also very, very important, even more important, to talk to your doctor about the non-motor symptoms, because these are the symptoms that change quality of life. And the motor symptoms are really tip of the iceberg, what you see, a little bit of shaking. So don't hesitate to talk to your doctor about the other things that the doctor doesn't see. How's your bowel movements? How many bowel movements per week do you have? Are you having a lot of pain and strains with bowel movements? Are you having a lot of dizziness every time you stand up? These are the important things to discuss, because a lot of them can be treated and can be modified with different lifestyle modifications. So here, I want to show you how research has changed. Initially, back in 1960s to 80s, there wasn't any. When you look at the number of research that was done back in the old days, there wasn't any. People didn't think of GI dysfunction as an important thing in Parkinson's disease. But when you search on PubMed, which is our Google for new research that comes out, or the publications, when you put the word Parkinson and gut, look how many, you get a lot of different publications. So more and more attention to the effect of gut in Parkinson's disease over the past several years. Now, in one of the studies, what they did is that they compared patients with Parkinson's disease to patients who didn't have Parkinson's disease, but had the same age. You see that people who have Parkinson's disease in green, they have a lot more drooling, they have a lot more problems with swallowing compared to their other healthy controls that have their same age. These patients often had a lot of nausea, they had constipation, problems with defecation. These are all common symptoms that we see in Parkinson's disease. And I tell you why we have all these. One of the major reasons why we think we have all these symptoms that you see is decreased in motility of the GI tract. GI tract really starts from the oral cavity, and then esophagus, the stomach, the small intestine, colon, all of these are all different segments of our GI tract. And when you have decreased in motility, it means that you have a slower movements in the whole GI tract. What will happen here? The food that you eat gets stuck in the stomach and it doesn't move forward. So you feel full, you feel like maybe at times nauseous, you don't want to eat anymore, decreased appetite. Then you will have constipation because the content of the GI tract is really not moving forward, constipation. And also you can have problems with defecation. Why do you have problems with defecation? A lot of you probably have noticed that sometimes you have a spasm in your muscles, in your leg muscles, or in different parts of your body. Muscles are a little tight in the spasms. At the end of our rectum, we have a muscle or sphincter that that closes the rectum and doesn't let the stool to come out. That muscle needs to relax in order for the stool to come out when we're ready to defecate. In Parkinson's disease, because of all the spasms, that may fail to do so. So the spastic sphincter will just stay tight, and you feel like whenever you're going for a bowel movement, you have a lot of strain, you have pain, you have to push, it's just not coming out. That's a little different than constipation that you have, and you just cannot go to the bathroom because of the frequency of the bowel movement is less. It's important to talk to your gastroenterologist because the two of them are treated a little differently. Sometimes when you have a lot of a spasm in that sphincter, sometimes they can treat it with a little bit of Botox injection and relax the muscle. So you can have regular bowel movements without that pain. So again, important to talk to your gastroenterologist if that's the problem. I included this picture really here to show you that all segments are involved. We know that swallowing function is also involved in Parkinson's disease, the very beginning of the GI tract. Why is that a problem? In general, what happens is that we need a lot of coordination between muscles in order to be able to push the bolus of food back to the right pipeline, and it goes down to the esophagus. When that coordination between the muscles are impaired, what will happen that often we feel like the food is stuck in our throat, just doesn't go down, or often we cough. One of the important strategies that I always tell people, and if you have had speech and swallowing evaluation, you probably have heard of that, is that while in the past, maybe 20 years ago, you could eat at the dinner table while reading your newspaper and the TV was on and the grandkids or your children were running around and it was noisy. Nowadays, you really have to think about eating as a task that needs all of your attention. You can't be doing multitasking while you're eating because you need to pay attention to all that coordinated movements of the muscles in order for the food to go down correctly. You have to have a good posture, be sitting up upright, and continue to be seated for 30 minutes after you eat in order for the food to be processed and move forward appropriately. So you need a quiet place for eating. You need all of your attention to eating. You need your TV to be off. You need your animals to be around, to be in a different room, not around. And that way you can pay attention, and the act of swallowing with a little more attention will go smoothly. Other things that you can do for better absorption of medications is that you can, as I said, stay upright or even go for a short, very slow walk. Avoid going to bed immediately, because that will not be very good for your absorption. So one of the things that you will very often hear is the gut-brain axis in Parkinson's disease. So I thought I really touch on that real quick about the gut-brain axis. In the past, we thought that Parkinson's disease is something that starts right in the brain and causes changes in the brain, and we see all the tremor and then later on see the memory problems and all of that. But then later on in 2003, so now kind of old theory, we started thinking that no, maybe there are other ways that the pathology starts spreading, not starts from the brain, but maybe it starts from the olfactory bulb, or maybe it starts from one of the major nerve, GI nerves, which is the vagus nerve, and then finds its way through the brain. To the brain. So that's what's called the dual hypothesis. Then later on, we learned that no, maybe there are two different types of Parkinson's disease. Maybe there are people whose Parkinson's disease starts in the brain and later finds their way to the GI tract. Or maybe there are people that start in the GI tract, and from the GI tract, the pathology finds its way to the brain. Both forms may happen in our patients, and we don't really know if 100% of patients start from the GI tract and go to the brain. But we think that it's not the case that all of the patients definitely starts from the CNS. We think that a combination of two exists. Certainly in some of the studies that they've done, they found that people who just randomly died in accidents, when they looked at their GI tract, when they did autopsies, they saw that, oh, this person had the pathology of the people with Parkinson's disease in their GI tract. So maybe in 10 years, this pathology would find its way to the brain, and this person would have Parkinson's disease. It just happens that we are seeing it in that early moments of development. So that's the current thought about the spread. This is a very busy slide, I know, but I want to show you how we think the spread happens. Our initial thoughts, our initial theories, as developed by a very important scientist, Barak, and his colleagues, that said that the pathology starts in the lower parts of the brain and gradually goes higher up to the brain and involves the whole brain. So here we see that people start developing some problems with the sleep, then people would develop some problems with tremor and walking, and then people develop memory problems. Now the scientists believe that actually, no, maybe the spread is even further lower in the peripheral nervous system, in the GI tract, and perhaps, and then from the vagus nerve, almost like a canal from the peripheral nervous system into that vagus nerve and then into the brain. And this was supported by some studies in bariatric surgery, when people have just resection of parts of their stomach in order to lose weight. They have to cut some of the nerves of the stomach as well. And when they cut the major nerve of the stomach in the bariatric surgery, they found out that these patients will not develop Parkinson's disease. The vagus nerve was cut, and maybe that was the messenger that was supposed to take this pathology from the stomach to the brain. And since we cut it as part of the bariatric surgery, these patients didn't develop Parkinson's disease. That's a very interesting finding that tells us that maybe if we find a way to break that messenger, then we will not spread the pathology to the brain. And again, in another study that they did, they looked at the more advanced bariatric surgeries where they wouldn't just cut the whole trunk, but they would just cut some of the smaller branches of this vagus nerve. And those people whose smaller branches were cut off continue to have Parkinson's disease with the same rate as other people. That tells us that still this messenger was here and was sending the pathology high up in the brain. So nowadays we think of GI tract really as the mini brain. We think that there's lots happening in the GI tract, a lot of factors that may in fact start the process of the disease to start in the GI tract, and then maybe the brain is involved. We think that maybe there are some environmental factors that start the process. Something happens in the GI tract. The environment of the GI tract becomes a little pro-inflammatory, full of inflammation. And then what happens is that the cells become loose, and we call the wall of the GI tract a leaky wall now. And the leaky wall will allow for the toxins to get more easily into the blood and find their way up in the brain. So that's one hypothesis. And with that, I want us to start thinking about microbiota. You probably have heard about microbiota. What is microbiota? Microbiota are the millions and trillions of bacteria that live in our GI tract. These are, some of them are very good bacteria. We need these bacteria. We need these bacteria for absorption of our food, for a healthy function of the GI tract. As long as they're happy, they're against inflammation, we're good. But the moment they are pro-inflammatory and they cause a lot of trouble, they stop the process of absorption of the nutrients that we need. We start feeling that we have weight loss, we have gas, we have a lot of problems with constipation. So changes in microbiota is one of the important topics that we've been thinking about. A happy anti-inflammatory microbiota moving forward to pro-inflammatory microbiota. So it's always been a question for scientists: how can we prevent these changes? We call it dysbiosis. How can we change this a transfer of good bacteria to bad bacteria? Can we do anything? So that's why a lot of people think about, oh, can I take like certain types of yogurt, or can I take supplements that will be good for my microbiota and will make it healthy? I'll tell you the quick and final answer, spoiler alert, that so far we haven't found any specific bacteria that will be good for our microbiota. We haven't found any of those bacteria that is healthy for us, for Parkinson's disease. So that's why we tell our patients that if you end up spending a lot of time on different types of supplements, really what are the ingredients of these supplements? All of these have been tested, and I'll show you some evidence that some of these show that maybe there will be some improvement in depression and some of the non-motor symptoms. But to narrow it down, we're still working on finding out what is that right bacteria that we need in order to have anti-inflammatory microbiome and a better improvement in our Parkinson's symptoms. One of the interesting studies, I don't want to spend too much time on this, but this is one of the interesting studies that was done on mice. So what we use, because we can't possibly test every hypothesis that we have on human, so we do use a lot of animal models. One of the common animal models are mouse. Mouse, what they've done is that they looked at the GI tract of the mouse who has Parkinson. We create a mouse model that has Parkinson's disease. And then we look at the GI tract of that mouse. We see that this typical GI tract of that mouse at times can be an angry GI tract bacteria, and this mouse will show a lot of Parkinson's symptoms. Then what they did is that they found the mouse that has perfect ingredient of the GI tract. It's very anti-inflammatory, just clean, and gave that in content of that GI tract of that good mouse to a mouse that wasn't doing very well. And the mouse started doing really well. Their symptoms started getting better. So that shows that if there was a way that we could improve the health of the GI content, of the content of the GI tract, possibly our symptoms could be better. So that's the base of all the studies that look more into fecal transplantation. Can we transplant a stool from one patient who's doing extraordinarily well to someone who's doing very poorly, and see if they will have improvement in their motor symptoms? And the short answer is yes, we can do that. Now, so when we start thinking about how to improve gut microbiota, how to improve health of gut, we should start by thinking about lifestyle modification. And we always talk about eating healthy, eating healthy, eating healthy, lots of vegetables, lots of fruits. We know that vegetables and fruit and healthy eating in general not only is good for your Parkinson's disease, it's good for your health, it's good for your heart. And that's the easiest thing to do. And that's where I tell everyone, if you want to spend money on supplements, please instead spend money on your healthier eating of berries. And some of these can be expensive, but if you're going to spend money on supplements, you might as well spend your money on these healthy eating patterns. Then another point that I want to get to is that even more recently, a lot of my patients have been asking me about H. pylori infection in the stomach, H. pylori, that can have an effect on the way they respond to their medication. I want to touch on that briefly, and then we will talk about probiotics and from there. Let's start with fecal transplant. So what is the difference, first of all, between prebiotic and probiotic? Prebiotics is all the healthy stuff that you eat, vegetables, berries, all the good things that you. Probiotics are all the probiotics that you see on the shelf of the stores. And those are, as I said, they may have some good ingredients, some bad ingredients, some of them have sugar, so you really have to be very careful with those. In one study, they said, okay, let's just do the transplantation of the fecal ingredients of one person who's doing really well with Parkinson's disease to someone who's not doing very well. When people received fecal transplantation, their motor symptoms improved after 1 month and continued to improve after 3 months. There are also non-motor symptoms like feeling depressed, anxiety, constipation, all those improved as well at 1 month and 3 months. Their quality of life too improved at 1 month and 3 months. They didn't, a lot of these patients did not continue to improve. This is the not improved patients are, you can see the majority did not improve up to 24 years. But a lot of these patients had improvements at 3-4 months. So this is a significant finding that if you do fecal transplantation every 3 months, perhaps you can have improvement in quality of life, motor symptoms, and non-motor symptoms. but it's a little hard. It's a procedure. It's a hard procedure, and it's still at the level of clinical trials. So if you're interested, you want to look for it in a clinical trial setting. And that's one of the things that I always tell all of my patients. It's really extremely important to be very cognizant of what you're doing with your body. Don't let, if this is not an FDA approved procedure, don't just go to a clinic who offers it. This has to be done under clinical trial setting if this is not yet one of our guidelines of treatment, which fecal transplant still is not. So if you're interested, you should look for you should look for clinical trials that are recruiting for this. Okay, so we talked about importance of changes that happen in motility of the GI tract, the changes in bacteria that happens in the GI tract, and we talked about the hypothesis of how it can start in the GI tract and find its way to the brain. This is all the cascade of events that starts the process. But as patients will develop infection or changes in the bacterial inhabitants of the GI tract. One of them are a small intestinal bacterial overgrowth, or SIBO, that some of you might have heard about it. One of the common symptoms of SIBO is when you feel early fullness, you feel gassy, and your medications may not be working well. One of the things that we think, the reasons why we think people will develop a small intestinal bacterial overgrowth is that your small intestine movements slow down. As I said, all the motility or the movements of the GI tract slow down. Small intestine also slows down. So what is the neighbor to small intestine? It's colon. And so colon, that is also slow. The bacteria in the colon find their way to small intestine and start growing there. When they start growing in a small intestine, we have a condition called small intestinal bacterial overgrowth. What does it do to our small intestine? Small intestine is where our levodopa should be absorbed. So first, it will have a negative impact on absorption of levodopa. Whereas in the past, you thought levodopa is working very well for me. All of a sudden, you feel like this is not working. The medication is just not giving me the quote unquote that on time that I had before. I feel like my symptoms are not well controlled. The treatment of the SIBO is an antibiotic. It's called rifaximin. Rifaximin is an antibiotic that you should take for 6 weeks, and it will eradicate those infections. It will improve your symptoms. But the problem is we did not treat the motility problem in a small intestine. So the majority of people still have the underlying reason, so still develop the small intestinal bacterial overgrowth yet again. So it's not one of the things that is commonly suggested for treatment. We always talk to our patients and say, if you have this condition, we can treat it. We can treat it and see how it goes. You may develop SIBO again, and your improvement in medication absorption that was seen after you had eradication may just go away again, and you have another infection of SIBO, or you may be in that narrow group that don't develop it again. Still, the guidelines do not really strongly suggest that we should treat SIBO because the underlying motility problem is not taken care of. Another part is H. pylori infection. H. pylori is another infection that can happen in the stomach. And when you have H. pylori infection in the stomach, you again have problems with absorption of levodopa, and some percentage of levodopa may even be deactivated by that bacteria. And so you will not have a good response to your medication if you have H. pylori infection. Some suggest that maybe we should treat H. pylori infection in order to have improvement of symptoms. H. pylori is also associated with some other conditions. For example, some absorption of some important nutrients in our diet. It may be associated with some cancers. So your GI doctor is the one who should decide whether you should treat H. pylori or not. One thing that I should tell you is that in one study, they compared people who had H. pylori and they treated H. pylori to see, just by treatment of H. pylori, will you have improvement in symptoms of Parkinson's disease? They found that there wasn't any improvement. So if you're going to treat H. pylori with antibiotics, you should discuss it with your GI doctor, and that should be for all GI reasons, not for Parkinson reasons. Because in the studies that we did, we didn't really find that if you treat that H. pylori, you are going to have improvement in Parkinson's disease. We did not find such a correlation. So because I get this question very often, I say that this is yet another reason why some people who have H. pylori will have ulcers in their, because it's irritation. They can have ulcers in their stomach, they can feel uncomfortable, they can have an impact on their absorption of nutrients. So discuss it with your primary care, discuss it with your gastroenterologist, and don't assume that your Parkinson's symptoms will be better once you treat it necessarily. So I do want to go back to motility one more time, because motility problems and motility movement problems of the GI tract are one of the important reasons for many symptoms that we commonly have. A lot of patients will, as the disease progresses, will complain about weight loss. And that's commonly not only because of the tremor that they have, the dyskinesia or extra movements that they're using the calorie more, but also can be because of absorption problems because of these motility issues. One of the important reasons why people with motility problems with Parkinson's disease complain to us is that they have erratic response to levodopa. You may have experienced that sometimes you take your levodopa, it kicks in after 30 minutes. Some other time it doesn't kick in after an hour. Some other time it doesn't kick in, period. And so this is what we call erratic response. And it's very common with progression of the disease. And we think absorption of levodopa is one of the reasons why we have this erratic response. Why do we have it? The reason for that usually is that your stomach, as I said, as part of the GI tract, is a little slower. You have a lazy stomach. So stomach doesn't really push the contents out into a small intestine. What is in that content? Your yellow pill, your levodopa is sitting in your stomach and not getting to small intestine where it needs to be absorbed. If it doesn't get absorbed, you're just waiting for it to kick in while the yellow pill is sitting in the stomach and hasn't even absorbed in order to kick in. So maybe the lazy stomach decides that after 2 hours it wants to push the contents out, and it will push it out. By then, some of the bacteria have started working on the full pill, and while you took 2,500, instead of 100 milligram of levodopa to get to small intestine for absorption, now only 75 of it is getting to small intestine. Where it gets to small intestine is also slow and unfortunately is dealing with small intestinal bacterial overgrowth. So not all of it can now be absorbed, and you have some 25 of it absorbed. So you say, oh, levodopa kicked in after 2 hours. And even when it kicked in, it didn't give me that full feeling of on that I anticipated I should have. A lot of these are explained by motility issues that we have in the GI tract. This is a very interesting picture that was taken as part of an endoscopy. And so a gastroenterologist was doing an endoscopy on a patient looking into their stomach, and this patient just happened to have taken their yellow pill, which you can see right here, Cinnamate, an hour and a half before their endoscopy. So this was supposed to be out after 15 minutes for the levodopa to be absorbed and be working, while where you see here an hour and a half was still sitting in the stomach, and some of it you see is not in the whole pill again, and the bacteria is degraded is already. So we talked about problems with swallowing, and then there's another problem here with the competition of protein with levodopa for absorption. And we always talk about this, and if you can, and especially when you with progression, you are taking more frequent dosing of the medication, this becomes really hard to work on. And so I always encourage you all to not spend all of your day thinking, oh, has it been 15 minutes? Has it been 30 minutes? When should I eat? That brings on a lot of anxiety and have a negative impact on your quality of life. If you're taking levodopa very frequently, let it go. Try to maybe try to take your protein at the end of the day or the evening, where you're not that active, and you don't necessarily need levodopa. And if it's not absorbed, that's all right. But maybe try to, during the day, live more on carbs and the rest, except for protein, so you have better absorption. But don't constantly be thinking about it, because that affects your quality of life. If you're taking it 3 times a day, 4 times a day, it's nice to be able to separate food, especially food that has protein in it, from levodopa in order for better absorption. So you want to take your levodopa with empty stomach, and then an hour later take food, especially food that has protein. So this is a very short presentation of what we recently did with the SMART pill. Some of you may have heard about the SMART pill. Is a pill that you swallow, is the size of a big fish oil, and it will measure how fast your GI motility is. So we did a small study on patients with Parkinson's disease to see if transit time, is the movement of their GI tract, is different in people who have a good response, in people who don't have a good response. When they took the SMART pill, the SMART pill went through the different parts of the GI tract and told us, later when we got the receiver back from the patients, we could see, oh, this patient spent this amount, the SMART pill spent this amount of time, 2 hours in their stomach, and spent 3 hours in their small intestine, spent 50 hours in their colon. We could see that people with Parkinson's disease had very long time spent in their colon. Some of the patients who didn't respond right to levodopa spent more than 7 hours in their stomach and spent a very long time in a small intestine. Then we measured their levodopa level in their blood to see if their blood level of levodopa also is different. People who have a good response to levodopa, after 30 minutes of taking the medication, they have higher levodopa level, and gradually this comes down. Whereas people who had problems with motility, with more advanced disease, only with taking 1 dose of levodopa in the morning, they would have high levels, low levels, high levels, low levels. They would go through a cascade of changes in their levodopa level in their blood. And that's how they felt about their symptoms. So all of that problems, and we only have 1 stomach. And think about all the poor animals who have 4 stomachs. They probably have a lot more problems. So one of the ways to bypass the stomach that's lazy is to use different medications. And so continuous infusion of levodopa directly into small intestine, that's one way. Using patch that doesn't need to be absorbed in the stomach, that's another way. Continuous subcutaneous apomorphine infusion. These are all other ways. This is a dopamine agonist medication, Levodopa, dopamine agonist medication. They all have their pros and cons, and it's important to talk to your doctor about them. But some of it may not be a good option for you. I want you to know, especially if you haven't heard about it from your movement disorders doctor, it doesn't mean that this was ignored. Often you have reasons why you're not a good candidate for one strategy. But if you have a lot of erratic response where it's working, not working, working, not working, it's good to think about other possibilities. Briefly, I want to touch on constipation because very often we put all constipation problems under one category. I want you to be aware constipation, motility problems in the colon isn't just because of slowness in movements. It can be because of that the spastic muscle. If you have a lot of symptoms like a straining, pain, and complete emptying, you do want to bring it up to a gastroenterologist for more assessments. We talked about those, and there's several ways to treat constipation. You can use several over-the-counter medications, usually eating a lot of fiber, coffee, water, exercise. These are good approaches for improvement in constipation. But there are also newer medications for management of constipation. So if this is one reason where your quality of life is really impaired, again, it's very important to bring it up and talk to your doctor about it. We talked about different approaches for defecation problems, using botulinum toxins, injections, or maybe biofeedback techniques. Some of you might have used PT for severe constipation. Some of the specialized physical therapists can help with that as well. Let's move on to some really good approaches to how we can have healthy eating habits. I always say that every time you're going to eat something, remember that it's going to your GI tract. It's going to define how you're feeling. If it's going to define if you're feeling ready to exercise or you're just really bloated and you just want to stay in bed all day. You are what you eat. So be very cognizant of the things that you eat, and don't spend all of your time thinking about supplements. Spend more time on newer recipes that are healthy for you. The reason why it matters is all of what we talked about is the leaky gut. If the gut, the junction between cells and the gut are not really tight, and some of this is going out, better not be toxins. So you want to, for a happier, healthier life, be eating more of the spices, more of green vegetables, things that help you have not only better GI motility, but also less constipation, less of those severe symptoms that can be bothersome for you. In general, I always say try to avoid highly processed food. Try to avoid red meat. But also, I always mention that a lot of these things can be joy of our life. So if you really love a steak, don't completely put it out of your life, but make it a treat for yourself. Make that food that's not necessarily the super healthiest food a treat for yourself, not a routine. Routinely, you should be eating healthy. You should be eating fresh food, and you should eat lots of nuts and seeds. And maybe that piece of a steak can be a treat for your 70th birthday or your 50th anniversary. But keep it for an occasion, and don't make it a routine. Very commonly, we briefly touched about this. Very commonly in Parkinson's disease, we see weight loss, and we talked about all the reasons for weight loss. Weight gain also is an important concept in Parkinson's disease. Why do we have weight gain? Because some of the group of the medications will cause problems with binge eating. So you find that in the middle of the night, you're waking up and always you're making a trip to the refrigerator to see what's there. Things that you can do, you definitely want to bring it up to your doctor, because especially if you're on an agonist, this may be one of the reasons why you should come off of it instead of just adding more weight. If you are the rest will be really lifestyle modifications. Sometimes I tell spouses, maybe we need a lock on the refrigerator. Maybe you want to wake up with him or with her when she wakes up and goes to the refrigerator, and just remind her, maybe eat some celery or eat something that satisfies the chewing, but not necessarily become added calorie. Drink a lot of good liquids. During the day, you should be drinking a lot of water. Yeah, and you should drink a lot of coffee. Coffee is really good, not only for constipation, but also for fatigue. In the morning, if you feel that you're generally, you have a lot of fatigue, it's important to drink 2 cups of real coffee, not decaf coffee, but coffee, real coffee in the morning, and then go for a walk or for your exercise. It's important to have some tea, a lot of good tea out there that you can try, not only great tea that you can try, and all of it, a lot of these different types of teas have anti-inflammatory properties that you can benefit, your brain will benefit from. And one of the important things, as we continue to emphasize how important it is to drink a lot of liquids, is to remember, if you drink a lot of liquids towards the end of the day, you're going to have a lot of trips to the bathroom in the middle of the night. To avoid that, you want to limit your drinking maybe after 7. I even tell my patients that if you are often having urinary frequency in the middle of the night, maybe an hour or 2 before going to bed, lay flat and then put your feet up for 30 minutes. That way you're really tricking your heart and your kidneys into cleaning that leftover amount of liquids, and then you can go to the bathroom before going to bed, and then maybe that will avoid 1 or 2 trips in the middle of the night. That's a good trick that will help you sleep a little better. But definitely drink less soda, drink less orange juice or any other type of juice that has sugar in it. That will be bad for your teeth as well. We often talk about what is an ideal shopping list. If you like chocolate, you want to stick with chocolate that is 80% or higher. But if, again, you find yourself that you're making a lot of stops at the chocolate part of the grocery store, maybe another reason why you should talk to your doctor. Some of these medications make you more interested in high calorie food and chocolate, and that's part of binge eating. Again, talk to your doctor and see if that's something that you should come off of some of these medications. There are lots of great resources out there for reading about what a good diet is and how to prepare a good meal for yourself. A lot of my patients who have had a very busy life throughout and always worked really hard. Now they're retired. I tell them, well, this will be your new job. Maybe become your own cook, use different recipes, use different spices, make a trip to grocery stores that you didn't try before, especially from different cultures, and you can find out if there are recipes that you didn't know about and you may actually really like them. So with that, I want to leave some time for questions too, and I will see, let's see.